Well, welcome to Chapter 10, the older adult patient. So, what age is commonly used to indicate the onset of old age? Well, normally we think of 65 as retirement age, so that's considered old. And I'm sure to all you guys, I seem old. Even the Beatles used to sing about, "Will you still love me when I'm 64?" But now we find that what the definition of old age is just means they're advanced in years. We can have young old people and old young people, right? So most definitions mean having lived a long time, someone who is advanced in their years. Aging is the process of growing older or more mature. Aging is an ongoing developmental process that begins at conception and ends in death. Gerontology is the study of aging, and geriatrics is the biomedical science of old age and the application of knowledge of aging to the prevention, diagnosis, treatment, and care of older persons. And this is a fairly new branch of medicine, and it's really important because our elderly patients are growing older and staying older for a longer period of time. In other words, they're not dying as young as they used to. So registered nurses who demonstrate appropriate knowledge and experience can seek gerontologic nurse credentialing. So as I said, typically this refers to professional level nurses with advanced degrees, the gerontologic nurse. And employment settings for licensed vocational nurses or practical nurses have shifted from traditional hospital-based positions to a range of community-based long-term care and home health care positions. But I'm hoping that in the near future it will go back to hospital-based because really the RNs are just costing hospitals too much. So what is ageism? The word ageism. Well, who introduced the concept of ageism anyway? Well, it was a person by the name of Butler. Now, this is not in your book, so you might take note that Dr. Butler came up with the concept of ageism, and his definition is, and his fear really was, it dehumanizes older people. So by stereotyping and discrimination against people of their age, it dehumanized older people. You didn't take them for who they were anymore. You create assumptions without assessing the individual. Just by looking at someone, you think, oh, they're old. They think old. But now we know that there's some young people that think old, and there's some old people that think young. It allows those who practice ageism to distance themselves from their own aging. That's a big thing. We never think we're aging. We never think of ourselves as aging because we're always young at heart, right? So I don't really feel, and you may not feel as old as you are. It influences the behavior of its victims. So the way the elderly is treated sometimes affects their behavior. So I want to read to you, and if you would turn to page 168, this is one of my favorite poems. It's a very important thing that I feel is important in this book, and excuse me if I cry because sometimes it makes me cry. So what do you see, nurse? Do you see? What are you thinking when you're looking at me? A crabby old woman, not very wise, uncertain of habit with faraway eyes, who dribbles her food and makes no reply when you say in a loud voice, I do wish you'd try, who seems not to notice the things that you do and forever is losing a stocking or shoe, who, resisting or not, lets you do as you will, with bathing and feeding the long day to fill. Is that what you're thinking? Is that what you see? Then open your eyes, nurse. You're not looking at me. I'll tell you who I am as I sit here so still, as I do at your bidding, as I eat at your will. I'm a small child of 10 with a father and mother, brothers and sisters who love one another. A young girl of 16 with wings on her feet, dreaming that soon now a lover she'll meet. A bride soon at 20, my heart gives a leap, remembering the vows that I promised to keep. At 25 now, I have young of my own, who need me to guide and a secure, happy home. A woman of 30, my young now grown fast, bound to each other with ties that should last. At 40, my young sons have grown and are gone, but my man's beside me to see, I don't mourn. At 50 once more, babies play round my knee. Again we know children, my loved one and me. Dark days are upon me, my husband is dead. I look at the future, I shudder with dread. For my young are all rearing young of their own, and I think of the years and the love that I've known. I'm now an old woman, and nature is cruel. 'Tis jest to make old age look like a fool. The body it crumbles, grace and vigor depart. There is now a stone where I once had a heart. But inside this old carcass a young girl still dwells, and now and again my battered heart swells. I remember the joys, I remember the pain, and I'm loving and living life over again. I think of the years, all too few, gone too fast, and accept the stark fact that nothing can last. So open your eyes, nurses, open and see. Not a crabby old woman, look closer, see me. And I feel that that's an important poem because when you look at your patients, don't just see who they are, look deeper, ask questions about them, find out who they really are. They aren't just a number or an age or a name even. They're a real person. I feel this is really important. Sorry if I got a little teary there. All right, so what are some myths about aging? And I put the page numbers on here because this is kind of a long chapter. Pretty much all the verbiage that you need to know is on the slides, but I do want you to read the book as well. So on page 168, 169, so cognitive, some cognition or your thinking declines with age, but educational and intellectual experience build cognitive reserve. So what that means, all these Sudokus and crossword puzzles and all these mental challenges to the brain make more connections. We have so many neural synapses and connections in our brain that we don't use. But if we keep learning and keep educating and keep using our cognitive reserve, we can stay younger longer. So the speed and efficiency of processing and storing information does decline, so it might take a little longer to read a book, a little longer to do a crossword puzzle, but just keep doing them. It can improve. Dementia is a progressive decline in cognitive function. It is not a part of normal aging. There is a sexual component to aging. The response is slower, and some medications can affect the sexual desire of the elderly, but it still can be there. You will find that in some of your homes. You take care of your patients. Financial, many people continue to work despite retirement age or despite growing older. They might even retire and then get a little job, maybe a greeter at Walmart or something. Just something to keep them busy, because busyness will keep you feeling younger. Having a purpose helps you feel younger. So despite intense interest in longevity by so many cultures, scientists don't always agree on precisely why or how humans age. So the knowledge of the underlying mechanism of aging is critical to develop a system that considers the special needs and health conditions of an aging population. So we're going to learn the underlying mechanisms of aging. What is normal? What is not normal? So some theories of biological aging. Most experts now believe that aging is not explained by one single theory, but represents many processes working simultaneously. Most theories of aging fall into three classifications. Stochastic, which is like random events of aging, random events occur that make you age faster or slower. Non-stochastic, in other words, aging is a predetermined process. You're going to be this way at 20, you're going to be this way at 30, this way at 40. We talked about Erickson in last week, and Erickson put us in stages, but if you notice, those stages were a wide range of ages because no one fits into one particular stage at one particular age. So evolutionary is a natural selection. So the stronger are going to live longer, weaker may die younger, and that's natural selection. So physiological changes of aging, well, the brain size is generally thought to decrease with age, although evidence for this belief isn't conclusive. When does the loss of neurons begin? Well, if you don't use them, if you don't use it, you lose it, right? What would you expect a 70-year-old patient's arterial oxygen values to be? Well, in the not having any problems category of lung issues, they should run at about 95%. If you did an O2 saturation, 95%. Some do more, that's true, and some are less. But the people who have a less O2 saturation might have some sort of interstitial or lung disease. So we're going to talk about the cardiovascular system, the renal system, integumentary, which means what? Let's get your, see what you learned in fundamentals. Skin. GI system, musculoskeletal, and sensory system. So we're going to be talking about all of those. So the nervous system, let's talk about that, page 170, 171. It's essential to know that in the absence of disease, most aged people remain alert with functional intellectual capability. Now, functional is always going to mean what you do. So what you do and your intellectual capability. That you normally will have a sound judgment, be creative. Sometimes, however, and it's important to remember that memory lapses, isn't it funny I just said it, remember, memory lapses? Okay, memory lapses such as forgetting a name or misplacing an item are common normal memory lapses. Very common to forget a name or misplace an item. One thing I found that's easy to do is kind of go back to where the last time you saw it, and maybe by tracing your steps back or forward, you can find what you misplaced. Only modest impairments in memory and learning after age 70 in most people who are relatively free from major disease. Changes may result in a progressive slowing of responses, problems with short-term memory, and altered learning. So it might take a little bit longer to learn a new skill. That's why going back to school at a later age is a little rougher. You can do it, but it's harder. Decreased conduction speed of neurons might occur. So short-term memory loss, frequently a concern of the aged. Long-term memory may remain intact, and that's very true. So long-term memory, I can remember back when I was a kid really well, but I may not remember what I did yesterday. So that's a very common thing with the elderly. 40% will develop Alzheimer's disease within 3 years. Others do not progress to more serious impairment. So 40%. Stimulus input into the neurons are dependent on adequate tissue oxygenation. So anything that stops the oxygenation, whether it be an accident or respiratory or cardiac. It will decrease the oxygen into the neurons, which will then decrease the nervous system capability. You may not remember planned daily activities, but easily recall young adulthood experiences. Mild cognitive impairment, or MCI. Now I want you to remember those initials because we're going to come back to that a little bit later. So persistent memory problems with otherwise normal cognitive function. 40%, I'm repeating this, must be important. 40% will develop Alzheimer's disease within 3 years. Others do not progress to more serious impairment. So strategies to cope with memory problems. Things to improve memory performance. So one way to remember if you have a memory problem is mnemonics. And that's stringing together known and unknown information. It may be like ADPI is how we remember our nursing process. Do you remember the mnemonic for the rainbow? So that was Roy G. Biv. Red, orange, yellow, green, blue, indigo, and violet. Remember that? So there's also rehearsal memory training, and that's just learning something by repetition. Also, we know that there's several ways of learning. There's ways of visual, auditory, and then a combination of both. So what are you? And that may lead you to how you might study. Do you do better listening to these audios? Do you do better reading the book and highlighting? Maybe make note cards. There's different ways, and as we go along, I'll be happy to give you some other ideas of how to help with this nursing process. Okay, temperature regulation. So the elderly have a low tolerance for extremes in temperature, and that means either warm temperatures, so don't put them out. It's great to put them outside because they get their vitamin D in 15 minutes. If they have shorts on, you can get your vitamin D. But don't leave them out there very long. First of all, they can get burned. Their skin is very sensitive. They might be it might put them at risk for cancer of the skin cancer. Also, they have a low tolerance for cold. So be sure that they have blankets to keep them warm in the cold, or something on their head, or gloves. Pain perception and tactile sensation might change. Some researchers have found the dulling of pain and tactile sensation in older persons, but these results are not consistent. I'll give you an example here. My mom had really bad neck pain for it seemed like a really long time, and we'd put one of those heat packs around her neck, and then one day she suddenly didn't have neck pain. Now, do you think the problem went away? No. The pain perception was less. So it does happen with some people. Now let's move to the respiratory system, starting on page 171. I have several slides on this. The forced vital capacity and the vital capacity and maximum breathing capacity is all thought to decrease progressively with aging. And those things are related to atrophy or weakening of the respiratory muscles. So in the chest, the respiratory muscles get weaker or atrophy. The patient tends to take weaker breaths, shorter breaths. That's why it's going to be one of our main goals to have our patients take deep breaths and cough, because we don't always. I even have an Apple Watch that says breathe, and it's sensing that I'm not taking as deep a breath as I should, and I bet you may do that too. So you might stop and take some nice deep breaths every once in a while, just to be sure you get oxygen to all your vital organs. Also, another thing that happens is an increase in the anterior posterior diameter of the chest. And that's a result of kyphosis. Now, what's kyphosis? Hunchback. So if you take yourself and you kind of hunch over, you can see how that decreases how well your lungs can expand and contract. So that's why we always want to have a good posture. Vertebral loss of calcium can lead to kyphosis as well. So that's why our patients may need to be on calcium and get calcium levels checked. Also, that could be related to our thyroid, parathyroid. So that's always something that the physician needs to check. Calcification of costal cartilage. So the hardening of our cartilages almost turn bone-like, and then you can't expand, and they stay closed. So another reason for us to have our patients take deep breaths. And for us to start, my watch, as I said, it taps me sometimes. It goes tap, 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 take a deep breath, and so I take a nice deep breath. So you might do that too. Take a nice deep breath in through the nose and out through the mouth. So loss of elastic tissue surrounding the alveoli. So we've talked about the exterior of the lung. So what about the interior? We go to the larynx, the trachea, the bronchi, the alveoli. So the tissue around the alveoli lose their elasticity. And this is where our gas exchange takes place. So if you lose elasticity there, your gas exchange isn't going to be as good, which may explain why the normal is more 95%, like I had mentioned before, in a 70-year-old. And so remember that changes in the capillaries affect pulmonary diffusion, so that gas exchange is impaired. Also, I know I mentioned that a couple times. It's not because I'm old, it's because I do it for a reason, okay? Pulmonary blood flow decreases because of a reduction in cardiac output. So if the heart's not working, and I know that's our cardiovascular system, but remember the right side of the heart pushes to the lungs, pushes the blood flow to the lungs to get oxygen. But what if the heart's not working? It doesn't push it to the pulmonary system, and therefore it's not getting the proper oxygen that it should. Also, pulmonary diffusion, thickened capillary walls, and fewer capillaries surrounding the alveoli cause impaired gas exchange. I said it again. So what about exertional dyspnea? Now, what does that mean? Well, that means you get shortness of breath with exertion. A frequent complaint with the older adult. So walking down the hall gets them short of breath. But what happens? The more you do it, the less short of breath you get. I'm sure you may have experienced that even with yourself. You may start running and you can barely run 2 blocks without getting short of breath. But if you keep pushing yourself and pushing yourself, you'll develop some ability to go further. Also, the ability to perform prolonged strenuous work decreases with aging. So just the ability to perform that strenuous work decreases. Muscle weakness. One thing I want you to remember too is that ciliary action. Remember cilia? Not cilia that you had in fundamentals, but cilia, the little hair-like projections in your airways, normally sweep secretions from the airway so that prevent bacteria and other problems from getting into the lungs. Well, that becomes less efficient. So therefore, the elderly are more apt to get pneumonia. And as I go down in lung disease here, acute or chronic poses a threat to the older adult pulmonary secretions are handled less effectively, so their cough is a little bit weaker. Because remember, you've got those intercostal muscles, which are a little stiff. They may not be able to take as deep a breath, and therefore they're not able to have that force of a cough. And then again, the ciliary action, which normally sweeps secretions from the airway, becomes less efficient. And the bacteria then sits in the lungs. And then if the patient isn't moving around, isn't taking deep breaths, isn't doing good coughing, end up with pneumonia. And remember, influenza and pneumonia is the 7th leading cause of death in the elderly. So let's talk about the cardiovascular system now, starting on page 171 to 172. Sorry, I had to take a drink of water. All right, so resistance to blood flow in many organs increases as people age. And why is that? Well, they've developed maybe some changes due to cholesterol buildup has made the blood flow not be able to go as well or expand as well. I didn't explain that very well. I'll get to that in a second. Aging results in the development of whitish patches, fibrosis, and sclerosis in the endocardium. Maybe that explains it a little bit better. So fibrosis, stiffening, sclerosis in the endocardium. So it's not able to squeeze, it's not able to expand and contract as well as it used to. The heart becomes more rigid, and myocardial contractility is compromised. Remember, the heart's a muscle. So coronary blood flow may be reduced by as much as 35% because of changes in the blood vessels. And this could be a stiffening in the blood vessels, cholesterol buildup, plaque buildup, valves, valvular rigidity, the valves in the heart, and incomplete closure of aortic and pulmonic valves may result in murmurs. So when you do your head to toes, we did learn murmurs for a reason. All physicians take money, remember? Remember the position that the best heard, the positions on the chest where these murmurs are best heard. Heart cells have a decreased capacity to use the oxygen that they get, which may help explain the aged person's reduced tolerance for physical work. Pulse increases in force, so you might feel a bounding pulse or a forceful pulse. Now, when I say bounding and when I say thready, it is going to mean two different things. Bounding pulse usually means fluid volume overload. Thready pulse usually means hypovolemia or bleeding or shock. We'll get to that later, don't worry. Pulse pressure. What is pulse pressure? The pulse pressure widens well. Pulse pressure is the difference between the systolic and diastolic blood pressure. It represents the force that the heart generates each time it contracts. For many people, systolic blood pressure increases to approximately 150/90, and older persons are more likely to be treated for hypertension. And then again, remember, the heart's, what is high blood pressure? Well, it's the force that the heart has to work against the aorta. So if there's plaque buildup, if there's stiffening, it's going to take more for the heart to pump, which makes a higher blood pressure. So decreasing resting cardiac output. And cardiac output means the amount of blood pumped per minute. So between ages 25 and 65, the resting cardiac output is 30 to 40%. Now, how do we know that? Well, there is a cardiac echo that can test cardiac output, and 30 to 40 is a great amount. people who have poor cardiac function and it falls down to 25%, 20%, they don't have a well-functioning heart. So reduced cardiac output reflects a decreased heart rate and decreased stroke volume. Cerebral blood flow maintained. So the brain always gets the blood. It gets the best blood flow. And if you picture the aorta coming off of the left ventricle, where does it go? It has 3 branches. One branch goes right to the head, right from the heart to the head. So cerebral blood flow is maintained, and it's important. But other body systems, such as the liver and kidneys, receive a diminished blood flow. Again, plaque stiffening. Let's try a question. So which of the following statements about the aging nervous system is true? I'll give you a minute to read through with them. So the answer is D. Functional ability may not be affected significantly because reserve cells are able to compensate. And if you look at the other ones, are those true? Brain size thought to increase with age? No. Aging changes in the nervous system include decreased conduction? No. Let's read the rest of the question. And increased activity of the enzymes associated with synaptic transmission. So always remember, notice I jumped to conclusion. No. Oh, wait a minute, better read the rest of the question because it tells me more information. So when you're taking a test, read the whole question. Extreme impairments in memory and learning are observed in most people over age 70. Well, notice it says extreme impairments. Well, that's not right. They're not always extreme, right? Over age 70. So read the words, take your time. I'll give you the time here in the beginning, and read the whole sentence before you answer the question. So let's talk about the renal system. So by approximately age 70, the number of nephrons in each kidney is reduced by 1/2 to 2/3, with corresponding changes in the glomeruli. So do you remember how many nephrons are in a kidney? 1 million nephrons. That's amazing in each kidney. So inability to concentrate urine can lead to dehydration in older persons. That's really, really important to remember, and I'm going to prove that to you by talking more and telling you more about the renal system. So again, the older person is unable to concentrate urine, and that can lead to dehydration. So there's a decrease in filtration rate, plasma flow rate, and tubular resorption and secretion, a decrease. So fluids aren't filtrated as well, or reabsorbed or secreted as well. So that's why the patient's inability to concentrate urine can lead to dehydration. The amount of nephrons reduced by 1/2. The BUN, or blood urea nitrogen, tends to increase because blood flow to the kidney, or the kidneys aren't functioning well due to disease or trauma or some other problem. Total body water decreases by 1/2. Well, when you start with 1/2 body water, it's really easy to go to dehydration. So the older adult can become dehydrated easily. Their kidneys are less able to compensate for deficient fluid balance by concentrating urine. We also have something called antidiuretic hormone, which holds on to fluids so that we don't become dehydrated. But what if that's not working right? Also, they excrete excess fluid more slowly, so at risk for fluid volume overload if given volumes quickly. So we always check for edema in our patients to see if they're retaining fluid. What's the other clue that they're retaining fluid besides edema? Listen to their lungs. Their lungs may sound crackly or have rhonchi. So fluid volume overload, listen to their lungs and check for edema. Also, regulation of acid-base balance is less efficient. So the patient can more quickly go into acidosis, which is not good, can lead to illness. So some more on the renal system. Response to stretch receptors in the bladder wall. So now let's move down from the kidneys to our bladder. The stretch receptors to hold the urine in the bladder is decreased, and the signal of the need to void may be delayed until the pressure is high, because you send a signal from the bladder wall to the brain and says, hey, you got to go to the bathroom. But if that is slowed down, you don't get that message as quick, and then you don't feel the need to void until it's too late. Lax muscle tone may lead to incomplete emptying of the bladder, so they might not totally empty the bladder, and then they retain some old urine, and that can lead to a urinary tract infection. And why do they get urge incontinence anyway? What is that? They have the urge to go, and then they're incontinent. Well, that little valve, the little, I call it a door, but it's a valve. It keeps you from going to urinate. It's loose. It could be most common in women because of childbearing ages. Residual volume may cause subsequent urinary tract infections. So holding on to the urine for too long or not emptying the bladder can lead to UTIs. Incontinence, urgency incontinence may appear as a symptom of upper or lower urinary tract dysfunction, in other words, kidney or bladder. Conservative behavioral treatment is recommended as the first level of intervention. So that would be like scheduling or prompting voiding. So going every couple hours to the patient to see when they need to urinate, or knowing that after a meal they might have to urinate, or after drinking fluids. Environmental adaptation, so they have to adapt to the environment and learn what's acceptable, not acceptable, how far is the bathroom, how long can I hold it before I can get to the bathroom, and that can be at home or in a facility. And then there's pelvic muscle exercises called Kegel exercises, and that helps strengthen the pelvic muscles, and that's just tightening up the pelvic muscles to a count of 10, and then relax 10, and then repeat that. Those are Kegel exercises. So let's move on to the Integumentary System, page 172. Some changes that occur: dryness. And if you'll notice, think of the patients you've taken care of. Their skin is dry. They have a loss of elasticity. It may look wrinkly and dry. Uneven pigmentation and brown spots. Their skin's rough, not so smooth. There's looseness to their skin. And when you go to take a blood pressure, be sure you don't pinch some of that loose skin in your blood pressure cuff. The tissues are very thin and can tear easily, so we have to be careful handling our elderly patients. And also they can develop various skin lesions. Wrinkles, so those occur unless you get Botox or fillers, and those occur when the deep layer of the skin loses moisture and elasticity. Tiny creases and folds are formed. Extent and timing determined by genetics and sun exposure. So speaking of sun, skin that's exposed to the sun most often, such as the face, hands, and back of the neck, wrinkle more quickly. So be sure to apply SPF sunscreen, and it should be greater than 30, even 50, they say now. Persons in certain ethnic groups with thicker, oilier skin wrinkle at a slower rate, they have more moisture and their skin is thicker. So their melanin, which is what gives our skin our color, they have more melanin. Maintain a youthful, wrinkle-free appearance longer. And there's some great lotions out there too, but they are expensive to help us maintain a youthful, wrinkle-free appearance. So a big thing with the elderly, I'm sure you know this from taking care of some patients, pruritus. What is pruritus? Itching. Now, when you go through MedSurg 1, I'm going to consider it really, really important for you to learn these words. If you're not familiar with them, I will be sure and point them out. I do it for a reason, because it's important that we know medical terminology. And I know you had that class, but you can learn something, but if you can't apply it, you tend to lose it easily. So now we're going to start applying these words. So pruritus or itching, and that is related to a loss of oils in the skin. Now, to help with pruritus in our elder patients, suggest tepid baths, not too hot, not too cold. Use moisturizers liberally. If you don't have any at the facility, have maybe family members bring some from home. Avoid overuse of antiperspirants. Really, the elderly aren't that active to even need an antiperspirant, and they can be drying, as soaps can be drying. Perfumes, alcohol, so that's drying, and hot baths can be drying. Generalized itching should be reported to the healthcare provider because it can be a sign of illness like diabetes, liver disease. I'm going to jump to that one right now because the bile salts under the skin is what makes a liver patient itchy. Cancer can be a sign of cancer, or even kidney disease, because with the kidney disease, they're not getting rid of their waste products. So the waste products are being retained and it makes them itch. So, of course, hair loss. We lose hair where we don't want to lose it and get hair where we do want to get it. We don't want to get it, I mean. Hair gets thin. The color changes, maybe to white or gray. Men tend to grow bald, and women experience thinning of the hair on the head and genitalia. The number of facial and nasal hairs increase. As I said, we get hairs where we don't want them. I remember one day I had, I'm going to tell you this, sorry. I had a hair hanging from my chin. It was about 2 inches long. I didn't see it because guess what? Vision goes too when you get older. And nobody wanted to tell me. They were afraid to tell me. They didn't want to hurt my feelings, I guess. But when I finally did see it, or when someone finally told me, I was mortified. So just know that not everybody knows they even have these long hairs. Gray hair is caused by a slowing of the pigment production in the hair follicle. And it can be determined by genetics. Some people never go gray. And some people go gray early. It's irreversible. Well, you can color it. Notice the nails. They've become yellow and thick and brittle. GI system. So let's start at the mouth, in the oral cavity. So the teeth, they've lasted a long time, 70 years, say. So they begin to deteriorate because they've been used a lot, right? They're tearing meat, chewing. Maybe they haven't had good health care, dental care. It wasn't always known like it is now to take care of your teeth. You know how we have our teeth cleaned every 6 months? Well, I know my mom and dad never did that. It just wasn't the in thing to do. And now they're finding that inflammation in the mouth can even lead to inflammation all over the body, which can lead to heart disease, just as much as plaque. Also a decrease in functional taste buds. So the elderly can't always taste things. decrease in saliva secretion, their mouth is dry, and that can be related to medications, inadequate hydration, or even illness states, rather than just normal aging. Certain illnesses, cancers, can make them have decreased saliva, chemotherapy. Saliva tends to become more alkaline as the salivary glands secrete less talin and amylase. So the breakdown of the food they do eat, they don't get as much value out of it because the acid doesn't break down the food, and the talin and the amylase don't break down to give the patient their protein and their carbohydrates. Muscles associated with chewing weaken, so that's why we want to give soft foods, small pieces of food. Peristalsis is slower, and the risk of formation of intestinal diverticula increases. Remember, listening to the bowel sounds in all four quads is very, very important in your head to toe. You want to listen for peristalsis, and you might have to listen for a couple of seconds before you hear some kind of rumble, right? Because it's slow. Gastric emptying is slower. Gastric glands decrease the volume and concentration of hydrochloric acid. The intrinsic factor, the B12, is less, and pepsin is less. So they might be anemic as well. Less amount of calcium is absorbed. So that's why the sunshine sometimes helps, or maybe they need medication, calcium. Constipation is a problem, a big problem. It's a frequent GI complaint of the elderly. From decreased intestinal mobility, altered bacteria flora, and a diet low in bulk and roughage, medications, lack of physical activity, those all lead to constipation. So just a little bit more about constipation that's important to know is that usually in facilities, the bowel regimen is they usually give about 3 days. If someone hasn't gone in 3 days, I know a lot of people are obsessed with their bowels and they think they should go every day. But because of this decrease of motility, that may not be true. And they're eating less also. But you want to review their bowel regimen. So be sure that they do go every 3 days. That's why you ask, when was your last bowel movement? Why it's so important. And that's why it's documented also. So after 3 days, most facilities start with some sort of a laxative pill, right? And then a suppository. And then the third thing they would try is an enema. So after 3 days, they start trying to get the patient to go to the bathroom. If by 4 days they can't go, well, they could be impacted by 4 days. So it's really important to keep track of that when was their last bowel movement and to treat them. And remember, I'm going to repeat it again because it's important, 4 days could lead to impaction. That hard stool, because they don't have enough fluids, right? They haven't eaten enough roughage. They have decreased motility. And a decrease in activity, it can all lead to an impaction. So we want to educate our patients about diet, activity, how important it is to get up and move around. That goes for after surgery too, right? Increase their fluid intake. My mantra will always be in MedSurg 1 to cough, deep breathe, and offer fluids every 2 hours. You should, even if it's a sip of water or some sort of fluids every couple hours should help keep them hydrated. And avoid laxative abuse. So that can be as bad as, because then they become almost addicted to laxatives, or they can get, their mucosa can get damaged from laxative, the irritation of laxatives. Musculoskeletal system. So some age-related changes that occur would be decreased muscle strength, endurance, their range of motion. So that range of motion is something we really need to determine when we do our head to toe. We want to determine the ability of their joints to move. So move backwards, move upwards, and that's each side also. If the patient can do it themselves, have them do it. If you have to do it, then you test their range of motion. That's really important to do. Are they coordinated? Do they drop things a lot? And the coordination also is going to lead us to balance, which is going to lead us to the next chapter in a little while about falling. Their bone density will be decreased, and that can lead to problems. Elasticity and flexibility of the connective tissue. So if their range of motion is stiff and they can't move around too much, they're losing their elasticity and flexibility. So it's really important to move. That's why the elderly sometimes exercise classes. It's really good to do. And also as a nurse, we can always instruct our patients how to not bend and snap, no, but at least they can, move their arms around, lift their arms above their head, try to touch their toes as long as you're watching them, because we don't want them to fall. So arthritis is a big problem in the elderly. It's the most prevalent chronic disease in men, but it can be more severe in women. And it is the leading cause of disability. They get lumps all over their hands and feet. You've probably seen that in some elderly people. Now there's osteoarthritis, there's rheumatoid arthritis and osteoarthritis. So osteoarthritis is the most common form of arthritis. It's caused by damage to the inside surface of the joint. It can be caused from age, heredity, and obesity contribute to development of osteoarthritis. And remember that those large weight-bearing joints like knees, hips, spine, those are usually the ones that are most affected by osteoarthritis. Kyphosis, I mentioned that before in the respiratory section, but now I'll mention again in musculoskeletal because it's a curvature of the thoracic spine that gives rise to the bent over appearance of some older adults, the hunchback. I once had a lady whose back was so hunched that her chin touched her chest, and she was so stiff there that she then developed a decubitus on her chest from her chin. And kyphosis also leads to a lack of self-esteem because they look different and they can only look down a lot of times. Sometimes they can't even bend their head from side to side to look. I once had a patient in Manteca that she had the kyphosis that developed a decubitus on her chest, and she was so self-conscious, and she could only look down. She couldn't turn her head, so I'd put my head underneath there and say, "Hello, Mrs. Smith," just so that she'd feel recognized. Teach benefits of weight-bearing exercises. Walking, bicycling, and stair climbing help maintain bone and muscle mass. Assistive devices like a cane or a walker can help them walk and prevent falls. Even holding on to a side rail is an assistive device. Always recommended to walk with a rail if you're walking the halls. And when I say you, I mean the elderly. Avoid too much bed rest because of the detrimental effects of immobility. So, laying in bed, you can get more disabled than being up out of bed. And anyway, what I mean to say is that you get disabled quicker laying in bed. So you need to get up and move around. Teach range of motion exercises and assess patient's ability. That's something to document. And that's another thing I'm going to harp on is documentation, because your documentation is what other people are going to look at, and that's how they can tell if their patient's doing better or not. So documentation is important. So let's talk about the sensory system. So first we'll talk about hearing. So presbycusis, that's a good word to know. Presbycusis is hearing loss associated with age. 25% adults older than age 69 and half of adults older than age 85 are hearing impaired. Now, if you were a child of the 60s and you listened to music really, really loud, you might get hearing impaired at a younger age. Conduction deafness, blockage of the ear canal caused by excessive wax buildup, abnormal structures or infection. So it's important as a nurse to notice, does a patient suddenly can't hear? That may indicate that there's a problem, maybe wax buildup. Sensorineural deafness is damage to nerve tissue as a result of exposure to loud noises, disease, and certain drugs. Now, how do we help with that? Well, we want to look at our patients when we're talking to them, speak clearly and distinctly while we face our patients so that they can hear us. Remember, not being able to hear, not being able to see, not being able to move, imagine what it does to the self-esteem of an elderly patient. So if we can help in that, help them feel better, help them hear better, see better, get around better, we'll make for them a better life. So hearing aids often can help. So if a patient has a hearing aid, be sure that you get it for them. And also, if a patient can't hear you, be sure you ask them, do you wear a hearing aid? Maybe they have one and they just didn't bring it with them to the facility. So you might ask about that. Tinnitus is a good word. It's an annoying ringing or buzzing in the ear, and that is a sensorineural disorder. So let's talk about vision. So there's macular degeneration. It affects the macula, which is the part of the eye responsible for sharp central vision. So what does that mean? Well, they have blurry vision then. So they may not be able to make things out as well. Cataracts is a clouding or opacity of the normal transparent lens in the eye. Now, when you do your perla and you look in their eyes, are you seeing that pupil reactive quickly, or is it sluggish? Do you see a cloudiness over their eye? It could be a cataract. And if your pupil does not react when you check their eyes, ask them, have you had cataract surgery? Because if they've had cataract surgery, their pupils won't react. It's not a problem. They haven't had a stroke, but just be sure you rule out other things that can be wrong. Surgical removal of the clouded lens would be the way we would help with cataracts. Presbyopia, another good word. We had presbycusis, now we have presbyopia. So presbyopia affects the shape of the lens, and it is what causes the reading and other classwork to become difficult. So you might see the patient holding the book a little bit further away. Glaucoma is atrophy of the optic nerve, usually associated with elevated pressure of fluid in the eye. That little puff that they do when they do your eye check, that's checking for glaucoma. It's checking the pressure in the eye. Optic nerve carries visual impulses from the eye to the brain. Now, if you put your hand on the back of your head, that part of the skull is called the occiput. Occipital part of the brain is right there. And so the optic nerve goes from the eye to the back of the head. That's where the optic nerve sits, towards the back in the occipital part of the brain. That's why Your mom has eyes in the back of her head. Ha ha. All right, some chemosensory disorders that the elderly might experience, taste and smell. So they can't taste as well, smell as well. Causes for that could be nasal obstruction, allergies. Some drugs can do that. Some scientists believe that the decline in smell is due to a decrease in olfactory nerve fibers. It's important to remember that changes in the ability to taste can be caused by disease or drugs. So I know I said it a couple times because it's important. The inability to smell smoke, poisons, or other noxious odors endangers the lives of many older people. So they may not be able to smell a fire or other noxious smells. Dentures, hormonal changes, medications, and changes in chemicals needed to transmit taste are causes of older person's diminished sense of taste. Let's try a question. Which of the following statements about the aging nervous system is true? I'll give you a minute while I get a drink of water. So the answer is D. Functional ability may not be affected significantly because reserve cells are able to compensate. Psychosocial theories of aging. So older adults show cumulative developmental effects that produce unique personality styles, coping mechanisms, challenges, and growth. Family, friends, and the community are influential in the aging process and can support the individual in adapting to age-related changes. So it takes a village to help. And you know, our elderly have been through a lot. They know a lot. They have a lot of knowledge. They've been through a lot of changes in the world, and they have a lot to offer. So let's take value in that. So Erickson, remember from last chapter, he has a development of the elderly of ego integrity, where they review their lives and look back on their lives. Did I do enough? Oh, look at my children. They've grown and now they have chosen a wonderful spouse, and I have great grandchildren, and I must have done a good job. Makes me feel good to know that I've made a difference in someone's life. Versus despair. Now think about this. They're laying in bed. They can't move as well. They can't see as well. They can't hear as well. It can be so despairing. They also might feel bitter about the lack of accomplishment. They thought, I've had 70 years. What have I done? What have I done with my life? I've worked my finger to the bone, and what do I have to show for it? So it varies between ego integrity and despair. So be gentle with your patients because you don't know where they're at. Asking questions about their past life might help you understand them more. A disengagement theory is a gradual withdrawal of society and older people from each other. So they disengage from each other. They disengage from society because they don't want anybody to know about their losses, physical and mental. Activity theory. So that's the engagement theory, where they tend to withdraw. They tend to stay in their room. They tend to not be social. Activity theory describes successful aging as remaining mentally and physically active. So these are the people that go out and join other groups of people. They go to the activities room. They do play bingo and cards and put puzzles together and read books. Old age is part of the life cycle, and old people tend to behave in later years as they did throughout life. Now this is funny because let me tell you. So sometimes when I say old people tend to behave in later years as they did through life, well, what if they acted really like, let's say you had a lady and she dressed up in a short skirt, and this was true, it has happened, dress up, short skirt, high heels, lipstick, dressed to the nines, and she goes walking around the facility that way. She's always done that. That's the way she's always been. I had a patient once who wanted her hair done in curlers and lipstick on every night because that's what she did when she was younger. And that's her habit. That makes her feel good. It makes her feel young. So people tend to behave in later years as they did throughout life. If they were active in younger years, they're going to be active later. Important to remember. Old age has been described as the season of losses and despair. Experience despair, according to Erickson, if they have no ego. So that's that ego versus despair, according to Erickson. I want you to remember that. The patients, their sense of dignity or identity, fulfillment, suffer a deterioration of self-esteem, self-concept, and depression. So a lot of patients are depressed because they have lost their identity. They're no longer a father or a husband. They may have lost their spouse. They may not look like they used to. And have you ever seen a picture of one of your patients, how they looked younger? They look a lot different. And that's why I love to have your elder patients bring in a picture of what they look like when they were younger. It gives you a totally different look at the way they were. And that's like that poem of the older lady. Remember, they were once young. They did have a family. They raised a family. They worked hard. They were active. Maybe they were dancers. So we can't forget that. We can't let them lose their self-esteem or their self-concept. Sometimes they have trouble sleeping, and as nurses, what we try to do is keep them awake during the day, but we also want to find out why they're not sleeping. Now, my brother doesn't sleep well, and you know why he doesn't sleep well? He's afraid to go to sleep because they're afraid they won't wake up. So talk to your patient, find out why they're not sleeping. Is it something a sleeping pill would help? That's fine. But what if it's something else? So find out why they're not sleeping. Also, I just wanted to go through depression, that sometimes that can be manifested by the patient staying in their room and not wanting to come out. It's not that withdrawal that I talked about. It's more depression. So we have to try to figure out what the problem is by talking to our patients. And then we can tell this information to the doctor, and the doctor can prescribe something for the patient. So that's why we're so helpful. Remember, doctors only come to facilities every 30 days. So they rely on your assessments to give them information. Most older adults in the U.S. occupy a variety of family roles. Even now, we have some grandparents taking care of, I went to the next slide. We have some grandparents taking care of grandchildren because the parents have to work and can't afford daycare. But they can't run around as fast as they used to be able to, that's for sure. Activities of daily living. Now this is functional assessment. So activities of daily living is the way they function, their environment, their finances, the family, economic and community resources. Data useful during times of health, at the onset of illness, the beginning of treatment. So when did they get treatment? They may have seen signs for quite a while until they sought treatment, or maybe their insurance didn't allow them to seek treatment. So when did they get treatment, and how are they doing with the therapy that's been prescribed for them? So knowing what activities an individual performs alone, what activities require assistance is important to know. Do they need help going to the bathroom? Do they need help walking down the hall? And that helps them perform safely, and it's essential in defining their needs. If you know what they need, you can give that to them, right? The older person's database should describe both basic and instrumental activities of daily living. Now, do you think a diagnosis alone can tell you how sick an older person is or how much care they need? No, because remember, a continuum. So we have health and we have physical health. We have mental health and physical health. So they might be physically healthy, but mentally not so healthy, and vice versa. So we have to look at the person as a whole. Now let's talk about some drugs and elderly adults, because it's different. The way they can take drugs, different. Estimated that 44% of men and 57% of women 65 years of age and over take 5 or more prescriptions and over-the-counter medications a week. Approximately 12% of both genders take 10 or more medications each week. Age and disease-related changes slow the clearance of drugs, which increases the risk of adverse effects. I'm going to talk a little bit more about that on the next slide. So the liver and kidneys prepare drugs for elimination in the urine or in the feces. So everything goes through the kidneys, is filtered through the kidneys, and is filtered through the liver. Now, if those filters aren't working well, they're going to slow down the elimination of the drug. So they might be over-medicated because the elimination is slower. Age-related changes that have an impact on the inactivation of drugs by the liver include decreased liver size, reduced hepatic blood flow, and reduced liver enzyme activity on the drugs. Now let me repeat that another way because it's important to know. So age-related change that occurs that prevents drugs from being filtered the way that they need to be, reduced blood flow to the liver and kidneys, and that reduces the drug clearance, and reduce liver enzyme activity on the drugs. So they can have slow release of these drugs that are supposed to be rapid release. Then they get a buildup because it isn't all excreted at the same time. These changes increase drug concentrations in the blood. So some medications, the drug level is measured just to be sure that they aren't getting over-medicated, and possibly increase the amount of time it takes for the body to get rid of the drug. So there's a reduction in body size, so the patient tends to shrink, so there's less body to handle these medications. Decrease in lean body mass and water content, so there's less water, less fluid. Increase in fat, the fat cells may increase. Serum albumin concentration is low. Now this is important because albumin is protein, and we have albumin in the blood, and some drugs are albumin binding. Now, if there isn't a lot of albumin, which means they don't have a lot of protein, and a lot of elderly people don't, and they're given a certain amount of medication that's albumin binding, well, there's only so much albumin to bind to. Well, where does the rest of the medication go to? Well, it's free floating in the blood. It's not bound to anything, so they get over-medicated that way. A gradual decrease in blood flow to the internal organs in the abdomen reduces drug clearance through the liver or kidney. Well, that was said 3 times, wasn't it? So some risk factors for adverse drug reactions, so age, sex, race, more frequent in older white females, number of drugs consumed can be a risk factor for adverse drug reactions, dosage, the amount. Maybe they need less of a dosage. And remember, a person that's taking a certain medication, let's say they've been taking it for 10 years. Well, because they're older now, they may need less of a dosage because their organs are working slower. The duration of treatment, the severity of the illness, and patient cooperation. Are they taking their medication the way they should? Signs and symptoms of adverse drug reactions would be restlessness. They might fall, and that's especially true if you're giving them something, a sedation or benzodiazepine. They might feel depressed. Some drugs make them depressed. They might be confused. So always know what medications your patients are on before you label them as confused or irritated or combative. Loss of memory, constipation. So this is another thing going back to the GI system. If your patient's taking pain medicines, which a lot of the elderly do, and believe me, they should because they hurt. Things hurt. Arthritis hurts. Maybe they're on pain medicine, and they also, a lot of the theory is that they're older, so if they get addicted, so what, right? And you don't want them to be in pain, but that can lead to constipation. So keep an eye on the bowels, and also cooperation, urinary incontinence. Conduct baseline and continual assessments. So your continuous assessments day to day, hour to hour. When your CNA comes and tells you that the patient is acting different, go check on them. Don't just go, oh, well, that's okay. It's late in the day. It's early in the morning. They must be tired. Don't make excuses. If a CNA or someone else tells you that someone's acting differently, go check it, because you're really the one who's responsible. Drug interactions may be a problem, especially with over-the-counter drugs. That's why it's important to know what medications our patients were on at home. So some examples of that are aspirin and anticoagulants. Well, aspirin at 81 milligrams is a blood thinner. And anticoagulants, we know, are blood thinners too. So if they take them both, not good. Sodium bicarbonate over the counter can counteract diuretics. So those are important to know.